Welcome to the Platelet Couch. My name is Fazan Tatar. I'm a Senior Medical Science Liaison with Sobi North America. Today, joining me is world-renowned expert in ITP, Dr. Terry Gernsheimer from Seattle, Washington. Thank you so much for joining us today.
Thanks for having me.
Of course. So we're going to be discussing a patient case today regarding ITP and Doptelet. So to start off, how did the patient present to their healthcare provider?
So this was a relatively young woman, 27 years old, and very healthy young woman, very active young woman, and she had had about a month or two of severe menorrhagia. Her periods were extending 10 days. They were very severe. She was bleeding through. And in addition, as I mentioned, she was very active, so she could no longer be a runner. She was finding she was just too fatigued. She was doing her yoga, but at times she was getting breathless. So for those reasons, she sought out care with her primary care physician. Okay.
So did they have a diagnosis of ITP at this point or any history of suggesting a bleeding disorder?
No. In fact, she, as I mentioned, had been healthy. The only real challenge she had was a wisdom tooth extraction, which went completely normal. She had some bruising, but it was just on her leg. She had no other bleeding other than the menorrhagia, and she claimed, well, I'm clumsy and, I've been banging into the coffee table kind of thing.
Did she attribute the clumsiness to her fatigue or did it predate that?
Well, her fatigue was basically new, and the clumsiness, again, active, runner, not that uncommon in a young woman to see some bruising, and they've always presented saying, oh, it's nothing. It was really the menorrhagia that had her concerned.
Okay. So when they were at their initial provider, how were they managed?
So she actually didn't test at all for a bleeding disorder. She did have an a GYN exam. She underwent a pregnancy test, which I think was reasonable. And the primary care provider just assumed, this is a mostly vegetarian young woman. She's probably a little anemic from her diet and from her menorrhagia. And she put her on birth control pills, gave her some iron over the counter and said, you should be feeling better soon. Let me know if anything continues to go wrong.
Okay. And then what happened subsequently with the patient?
So, of course, it didn't get any better.
Right.
I think, she was still short of breath. She wasn't running. She was very fatigued. She still had terrible menorrhagia. So this time when she came back I think it was about a month later, the physician actually checked a CBC and saw that her platelet count, I believe, was in the 20s at that point. Put her on 80 milligrams of prednisone a day, so a pretty high dose because she was not a big young woman, and sent her on to a hematologist who saw her a couple of weeks later.
When the patient was put on steroids, did she have any issues with the steroids as well?
Well, she felt jumpy, which was the major thing that she said that she told this physician is, I feel jumpy, but the bleeding got better. But mostly she just didn't feel great on the steroids.
She also gained weight as well, correct?
Well, that took a while. She did, but after about a month or so on the steroids, her weight started climbing. And that was, this was a very fit young woman. It was very upsetting for her.
So when the patient presented to you, how did you approach their case?
So she initially saw a different hematologist who played around with the steroids. Initially tried tapering her. As soon as he got down to about 20 milligrams of prednisone, she crashed again. So then he tried dexamethasone, and same thing happened. She got 4 days of 40 milligrams of dexamethasone, no prednisone in between, crashed again. Her platelet counts would go up over 100,000 every time she got a good dose of steroids. But she was getting extremely frustrated. By the time she saw me, she had gained over 20 pounds. She was cushingoid. She was really jumpy and anxious, particularly when she was getting the dexamethasone. And she had been offered rituximab at this point, which was what was recommended by the other hematologist. And she got kind of scared when she heard it was an immunosuppressive. All she wanted was off the steroids. And so she came to me as a second opinion.
Okay. So what treatment options did you explore with her?
So I like to lay out everything. She was now going to get secondary therapy. She had clearly failed steroids because she crashed every time they tried to take her off. And so the two options that are really open to her at this point would be either rituximab or a TPO receptor RA. And so we went through both of them. She was not excited about using rituximab. I was not excited about it. I saw that she'd probably need vaccines in the future. And she didn't want immunosuppression. And I couldn't, I agree with someone at that point. Rituximab can be very useful in a young woman, but we usually try first to go with a TPO RA. And so once she decided she really didn't want rituximab, I went through the different TPO RAs that we could offer, and we discussed all of those options.
Okay. And so when you chose Doptelet for the patient, could you tell us a little bit more about why that was chosen as your therapeutic option?
Yeah. So she, first of all, could not see herself coming in weekly for an injection. And I thought that that was totally reasonable for a young woman who's very busy. The other thing is, number one, she was on iron. I had said, well, we could have the option of giving you IV iron. Again, she didn't. I think she really kind of wanted to avoid injections. And she had pretty much her diet laid out, her activities laid out. Every morning she had yogurt and her latte, and she took her iron, and she really didn't want to change any of her routine. So really the best option for her at that point was something that wouldn't be interfering with her diet or with her iron pills. And so we decided to go with Doptelet.
Well, Dr. Gernsheimer, we have a graph pulled up here. Could you describe to us how the patient responded to Doptelet?
Yeah, so I initially started her on 20 milligrams a day, which is the regular starting dose. She was on some steroids at that time, so I discontinued it. As the prednisone was tapered, the platelet count fell some. She initially had a very nice response, but with tapering of the steroids, she began to fall. And so at that point, I increased the Doptelet to 40 milligrams daily. With an increase, she actually overshot. Now, my experience has been that any abrupt cessation of any of these TPO RAs can result in a very rapid and severe drop in the platelet count. So for that reason, I didn't want to just hold the drug. And instead, I decreased the drug to 40 milligrams, alternating with 20 milligrams a day. She was still a little bit high after a week or two. And at that point, I decreased her to 20, 20, 40 on a basis like that. And at that point, we actually, she was already off steroids, and we were able to reach a really nice even keel where her platelet count kind of varied between 80 and 90,000, and she did quite well with that.
Okay. Since starting Doptelet, how long has the patient been on the drug?
She's been on almost 3 years now, I believe.
Okay. And then as our healthcare provider, how would you describe the patient experience with Doptelet?
She did very well. She was very happy with this. She was able to get back to her regular routines. She was very happy that she could continue her diet the way it had been because she felt strongly she wanted to continue her vegetarian diet. She had a routine of her latte in the morning and of her yogurt, and she wanted to continue to do that. She was able to get back to her running routine, continues to take yoga, lost the weight that she had gained with all that prednisone, and is quite happy now.
Okay, awesome. So what side effects have you seen with patients treated with Doptelet, and how do you manage those?
So she had none, and I've seen actually very few problems with Doptelet. I had one patient who would come in with headache, but other than that, I haven't really had any issues.
Okay. And then for this case, what would be the key takeaways?
I think the first takeaway is how badly steroids may be tolerated. The weight gain, the irritability, and the up and down with trying to taper. I think also this patient was on steroids too long. Normally, I would not keep anyone on steroids for more than 4 to 6 weeks. So pretty much I put them on steroids to make sure that their platelet count will increase. It actually, that increase in platelet count with steroids is very comforting because it's pretty much diagnostic when you see it of ITP. But at the same time, it's really important to get patients off quickly. I think the other thing that was very important is sitting down with your patient and talking about what the options are once you're getting to second-line therapy, because they have to feel comfortable. There are several options. There's different options for TPO-RAs. It has to fit the patient's lifestyle. And particularly this patient really needed something that fit with her diet, fit with her general routine, her general health and exercise routine, and Doptelet fit her best. She really wanted to avoid being on steroids. She wanted to avoid being immunosuppressed at all. There were vaccines in the future to consider. She had no plans on getting pregnant anytime soon. And so this was a very good fit for her.
Dr. Gernsheimer, thank you so much for joining us today on the Platelet Couch. For everybody at home, thank you so much for joining us. Please do watch the other videos in the series.
Doptelet, avatrombopag, is indicated for the treatment of thrombocytopenia in adult patients with chronic liver disease who are scheduled to undergo a procedure, and in adult patients with chronic immune thrombocytopenia who have had an insufficient response to a previous treatment. Before taking Doptelet, tell your healthcare provider about all your medical conditions, including if you ever had a blood clot, are pregnant, or plan to become pregnant. Doptelet may harm your unborn baby. Tell your healthcare provider if you become pregnant or think you may be pregnant during the treatment with Doptelet. Also tell your doctor if you are breastfeeding or plan to breastfeed. It is not known if Doptelet passes onto your breast milk. Do not breastfeed during treatment with Doptelet and for at least 2 weeks after the last dose. Talk to your healthcare provider about the best way to feed your baby during this time. Tell your healthcare provider about all the medicines that you take, including prescription and over-the-counter medications, vitamins, herbal supplements. Doptelet may affect the way other medications work, and other medications may also affect the way Doptelet works. TPO receptor agonists have been associated with thromboembolic complications in patients with chronic ITP. Thromboembolic events, arterial and venous, have been reported in patients with chronic ITP treated with TPO receptor agonists. Consider the potential increase in thrombotic risk when administering Doptelet to patients with known risk factors for thromboembolism, including genetic prothrombotic conditions and acquired risk factors. Monitor platelet counts for signs and symptoms of thromboembolic events, and institute treatment promptly. Serious adverse reactions that have occurred more frequently in patients treated with Doptelet compared to placebo was headache. The most common adverse reaction, occurring in 10% or more of patients with chronic ITP, were headache, fatigue, contusion, epistaxis, upper respiratory tract infection, arthralgia, gingival bleeding, petechiae, and nasopharyngitis.